So first, what is blood pressure? It is the measure of the pressure exerted by blood on the blood vessels during circulation. Remember our lecture yesterday and how we discussed the different blood vessels and how thick their walls are? That is all by design. One of the reasons is their necessity to withstand higher or lower levels of blood pressure. BP is determined by a number of factors, including cardiac output, CO, the amount of blood that the heart pumps each minute, peripheral vascular resistance, PVR, the ability of the vessels to stretch, the viscosity, thickness of the blood, and the amount of circulating blood volume. Decreased stretching ability of blood vessels, increased blood viscosity, and/or increased fluid volume may cause an increase in BP. Factors that impair normal regulation of BP may lead to hypertension. Many of these factors are not well understood. Sympathetic nervous system overstimulation causes vasoconstriction, and alterations in baroreceptors and chemoreceptors may lead to hypertension as baroreceptors become less sensitive from prolonged increases in pressure against the vessels. Then they fail to stimulate vasodilation through vessel stretching. Increases in hormones like aldosterone cause sodium retention and subsequently increased fluid retention. Changes in kidney function, altering the excretion of fluid, also results in excess fluid volume that may contribute to hypertension. Typically, it is recommended that individuals have a blood pressure screening annually after the age of 3 years, and more frequently if there is any abnormality. Stroke statistics consistent in reports per Johns Hopkins Medicine and the American Stroke Association. In the case of hemorrhagic strokes, constant pounding of elevated blood pressure on the cerebral vessels leads weakening of the vessel's walls and either one rupture of the vessels, which is known as a hemorrhagic stroke, or two, or plaque buildup, which increases risks for clot formation, or ischemia blockage in the brain. There is a high prevalence of hypertension in the USA. This becomes important as we look at hypertension, or elevated blood pressure, because long-term pounding of high pressure on the vessel walls can eventually lead to serious repercussions such as hemorrhagic strokes, or strokes that cause vessels in the brain to rupture and bleed. American Heart Association for Statistics and Pathophysiology, Irvine Page, prominent pioneers of HTN research. Hypertensive emergency occurs with elevations in systolic BP higher than 180 mmHg or diastolic BP higher than 120 mmHg, Brathwaite and Rife, 2019. If there is a risk for or progression of target organ dysfunction, such as MI, HF, dissecting aortic aneurysm, immediate BP treatment is required in an intensive care unit. Gradual reduction of BP is often desired to prevent decreased blood flow to the kidneys, heart, and/or brain. An IV medication such as nitroprusside, Nipride, may be given to reduce BP during the crisis. The nursing diagnosis risk for unstable blood pressure is applicable to the patient with hypertensive emergency. Modifiable risk factors: lifestyle, weight, sodium intake, not enough potassium intake, alcohol consumption, physical activity, compliant medication regimen, glucose control. Non-modifiable risk factors: family HX, race, age. Many risk factors for hypertension are modifiable, meaning patients can actively reduce their risk through lifestyle changes. One of the most important factors is weight control, as excess body weight increases the workload on the heart and contributes to elevated blood pressure. Even modest weight loss can lead to meaningful improvements in blood pressure readings. Dietary pattern plays a significant role in blood pressure management. The DASH dietary pattern is strongly recommended because it emphasizes fruits, vegetables, whole grains, and low-fat dairy products. Patients should be encouraged to limit sodium intake as excess sodium contributes to fluid retention and increased blood pressure. Increasing dietary potassium, when not contraindicated, can help counteract the effects of sodium and support blood pressure regulation. Regular physical activity is another key modifiable factor. Increasing physical activity improves cardiovascular health, supports weight management, and helps lower blood pressure over time. Patients should be encouraged to engage in consistent, moderate-intensity activity as tolerated and approved by their provider. Finally, glucose control is especially important for patients with diabetes or prediabetes. Poor glycemic control increases the risk of vascular damage and worsens hypertension outcomes. Nurses should reinforce the importance of monitoring blood glucose, following prescribed treatment plans, and maintaining healthy lifestyle habits. Addressing these modifiable risk factors supports long-term blood pressure control and reduces the risk of cardiovascular complications. Hypertension is managed using several different classes of medications, and it is important for nurses to understand that patients are often prescribed more than one class to achieve adequate blood pressure control. Each medication class lowers blood pressure in a different way, and therapy is individualized based on patient response, comorbid conditions, and tolerance. ACE inhibitors and angiotensin II receptor blockers, also known as ARBs, work on the renin-angiotensin-aldosterone system to reduce vasoconstriction and fluid retention. These medications help relax blood vessels and are commonly used in patients with diabetes or kidney disease. Nurses should monitor blood pressure, kidney function, and potassium levels when these medications are prescribed. Calcium channel blockers lower blood pressure by relaxing vascular smooth muscle and reducing peripheral resistance. Beta blockers decrease heart rate and cardiac output, which lowers blood pressure and reduces cardiac workload. Alpha blockers and central acting agents affect the nervous system to reduce vasoconstriction and sympathetic stimulation, but they may increase the risk for orthostatic hypotension and dizziness. Peripheral agents and direct vasodilators work by relaxing blood vessels directly, improving blood flow and reducing systemic resistance. Diuretics reduce blood pressure by decreasing fluid volume, which lowers cardiac output. Patients taking diuretics should be monitored for electrolyte imbalances, dehydration, and changes in blood pressure. Nurses play a key role in monitoring therapeutic response, identifying side effects, reinforcing medication adherence, and providing patient education. Understanding these medication classes helps ensure safe administration, early recognition of complications, and effective long-term blood pressure management. Hypertensive urgency refers to a severe elevation in blood pressure without evidence of acute target organ damage. Although blood pressure readings may be very high, there is no progression of organ dysfunction involving the brain, heart, kidneys, or eyes at the time of evaluation. This distinction is critical as it guides both treatment decisions and urgency of care. Patients experiencing hypertensive urgency may report symptoms such as severe headache, nosebleeds, shortness of breath, and significant anxiety. While these symptoms are concerning, they do not indicate immediate organ injury. Nurses should perform a focused assessment, monitor vital signs, and evaluate for any signs that could suggest progression to a hypertensive emergency. Treatment for hypertensive urgency is typically managed in an outpatient or ambulatory setting using oral antihypertensive medications. The goal is to gradually lower blood pressure, not rapidly reduce it, to prevent decreased perfusion to vital organs. Nurses play an important role in reinforcing medication adherence, monitoring response to therapy, and educating patients on the importance of follow-up care and ongoing blood pressure management. Hypertensive emergency occurs with elevations in systolic BP higher than 180 mmHg or diastolic BP higher than 120 mmHg, Brathwaite and Rife, 2019. If there is a risk for or progression of target organ dysfunction such as MI, HF, dissecting aortic aneurysm, immediate BP treatment is required in an intensive care unit. Gradual reduction of BP is often desired to prevent decreased blood flow to the kidneys, heart, and/or brain. An IV medication such as nitroprusside, Nepride, may be given to reduce BP during the crisis. The nursing diagnosis, risk for unstable blood pressure, is applicable to the patient with hypertensive emergency. When teaching patients who are prescribed medications for hypertension, it is important to emphasize safety related to blood pressure changes. Many antihypertensive medications can lower blood pressure too much, which may lead to hypotension. This can cause patients to feel dizzy or lightheaded, especially when changing positions. Dizziness increases the risk for falls, making patient education a critical nursing responsibility. Patients should be instructed to rise slowly when moving from lying to sitting or from sitting to standing. Taking a moment before standing allows the body time to adjust and helps prevent orthostatic hypotension. The nurse should reinforce the importance of sitting at the bedside briefly before standing and using support if needed. Hydration also plays an important role in maintaining blood pressure stability. Patients should be encouraged to maintain adequate fluid intake unless a fluid restriction has been prescribed by the provider. Proper hydration can help reduce symptoms of dizziness and support overall cardiovascular function. Reinforcing these safety measures helps reduce fall risk and promotes patient independence and well-being. Patients with hypertension need to understand that blood pressure control is a lifelong commitment. Even when symptoms are not present, hypertension continues to affect the body. Teaching should emphasize that long-term control requires a combination of self-care lifestyle measures and adherence to the prescribed medical regimen. Lifestyle changes such as healthy eating, physical activity, weight management, and limiting sodium all support blood pressure control and reduce long-term complications. Medication therapy is a critical component of hypertension management. Patients should be instructed to take their medications exactly as prescribed, even when they are feeling well. Hypertension is often asymptomatic, and stopping medications because symptoms improve can lead to uncontrolled blood pressure and increased risk for stroke, heart attack, and kidney damage. Patients should also be encouraged to report side effects promptly, rather than discontinuing medications on their own. Many side effects can be managed by adjusting the dose or changing the medication. For example, erectile dysfunction is a common and sensitive side effect associated with some antihypertensive medications. Nurses should address this topic in a professional, non-judgmental manner and reassure patients that alternatives may be available. Open communication supports adherence, safety, and long-term treatment success.